compassion can look really different to a lot of different people.
Are there ways where you can show compassion and be compassionate despite not having to spend tremendous amount of time?
That I look at them as if they were a friend or family member. I try to give them the same care, taking care of not just the patient, but also yourself as the provider.
How about the coworkers or the team, the nurses? How do you
It's difficult for everyone. We're all experiencing our own lives, and we have to understand that somebody in front of you is not just a patient, just like the person in front of you is not just there's a lot of red tape that patients have to go through on the other side. I remember even just trying to set up his initial oncology. Will say I have noticed that I have a lot more compassion and drive to regularly update. He has gone 9 hours without any updates. And it's been eye-opening. Everyone in healthcare is so overworked. We don't always have the time to just sit down.
Hello, Ms. Sarah Kellett. Welcome to the show, and thank you for joining us today.
Thank you for having me, Siva. I am a physician assistant that wears several different hats currently. I had kind of a circuitous route to get there, which I feel like is a little bit untraditional. I'm from the greater Philadelphia area, and I went to college in California at Pepperdine University, where I was a nutritional science major. From there, I decided to become a registered dietitian. So I went to NYU and did my dietetic internship there. While I was working as a dietitian is really the first time I ever experienced working with PAs, physician assistants. And that's when I sort of fell in love with the idea of that particular career. So I went back to school, back to the East Coast, and went to school at Philadelphia University, which is now Jefferson University East Falls, where I studied physician assistant studies. From there, I went and did a fellowship in emergency medicine at a local Philadelphia hospital where I still work. I did about a year and a half of spine surgery as well, still working in the emergency department while I was there because it's forever been my love to be in emergency medicine. And now I also teach full time at a local university. And I really enjoy teaching future PAs and really instilling a lot of the values that I think you're trying to focus on and instill in all of us, Eva, which is compassion in healthcare, taking care of not just the patient, but also yourself as the provider.
Nice. Thank you, Sarah. Thank you for the information. It was very um, good to understand that basically you went to dietary school and then all the way you got inspired by the physician assistants. But can you elaborate a little more about what inspired in the physician assistant position? And
Sure. So I, as a dietitian, was obviously very focused in on nutrition, wellness through nutrition, exercise. I really, really loved that and the chemistry behind all of it, everything that you learn in undergrad and grad school to become a dietitian. It was really, really exciting to me. But then I started to realize that I wanted to have a broader involvement with patient care. I used to round in the ICU. I was at a major cancer hospital in Manhattan, and I remember there was a PA on the team, and I really just was inspired by her ability to look globally at the patient, not just at the nutritional aspects, but just be able to weigh in and give her opinion on various aspects of the patient that were outside of just nutrition. So then actually after that, I went to California again and was working at a hospital in California where I would round with PAs and doctors, nurses, social workers, everybody. And I still again was gravitating towards the PA role and just the collaborative nature of the role and how big of a change that the PA seemed to bring. And their opinion was very respected and really valuable. And I just started to look more into that career and was really interested in it.
nice. Got it. So I know you already introduced the topic of compassion, right? You said you've been working with your students with regards to instilling those values, right? When I ask compassion, before we go into the values itself, if I ask compassion, what comes to your brain?
Sure. Just kind of off the cuff, compassion is feeling not just for the person in front of you, the patient, but also your own reflection, your own feelings. acknowledging those things. Compassion can look really different to a lot of different people. I think that the way I treat compassion with my patients is that I look at them as if they were a friend or family member. I try to give them the same care that I would give to any close friend, close family member, and just treat them with respect. I try to hear them, try to have them hear me, and have a mutual two-way conversation. So, specifically in healthcare, that's how I view compassion. Oh, I absolutely
That's
agree. I think the ability to take that into your care for patients, and it makes you feel like you're doing a good job for your patients. It makes you feel confident in the care that you're giving. I think treating them like you would treat any family friend, giving them those same recommendations, obviously understanding where they are and their healthcare knowledge and their abilities, which obviously are not reflective of maybe what yours are or mine are or our capabilities at home. But having those conversations with them, I think, is so important. Sure. So, some of our accrediting body for physician assistants, it is a standard that we do teach compassion in medicine. I don't believe that's exactly the wording of the standard, but it's along that vein of compassionate care, wellness, trying to prevent burnout. Because again, compassion is not just the patient and the patient, it's us as well. Compassion for ourselves and for each other, our colleagues as well. So a lot of our standards in our education surround those topics. So we have some professional practice courses where we have conversations about either difficult patients. We have difficult patients, standardized patient scenarios. We have interprofessional events, IPEs, with other professions, healthcare professions, nursing, respiratory therapy, pharmacy, social work, our medical students, and I'm probably forgetting some as well, OTPT, and we have conversations about safe discharge, what care looks like for each of us amongst our various roles, and how we can support one another, and lift each other up, and find ways and better understanding how each other works and what our roles are within the hospital and just healthcare in general. And on top of that, in lecture, I always try to talk to students just personally about ways to have conversations with patients, family members, things that just anecdotally pop up from experiences that are worth so much more than, textbook knowledge. Just those things, those little tidbits of knowledge that you or I may have picked up clinically with our patients, with coworkers, ways to make things just better for everybody overall. So yeah, it's a pretty big part of PA education. Obviously, not all of it, but it's very important to us and our profession to teach those qualities in students. So ownership of, sure, yeah. So I oversee the didactic curriculum in my program. So I sort of broadly oversee the entire curriculum where I am. Specifically, things that I teach or have a hand in are history and physical examination. So how to take a proper history, how to do a proper physical exam, what's pertinent, what's not pertinent, what's comprehensive, what's focused, sort of those basic entities, the bread and butter of medicine, and how to see a patient and interview them. I oversee our clinical medicine course. So essentially, any topic in medicine is within my course. And we break that up into different modules. So, say cardiology, pulmonology, GI, renal, etc. And then within those, I teach our HEENT content. I teach our GI and nutrition content. Kind of obviously, they give me nutrition. Infectious diseases, I oversee. And I'm missing a couple of things, but just sort of topics within that course. And then I run our surgery and emergency medicine course, just with my background in surgery, and then obviously emergency medicine. So every topic that falls under the emergency medicine umbrella, I lecture on that topic. We do bring in some guest lecturers here and there. So we have some people who have specific interests on my team, say in disaster medicine. So then that faculty member will come and teach that lecture on disaster medicine. Other than that, I assist and co-direct a lot of our simulation lab. So a lot of our OSCEs, standardized patients, technical skills, clinical skills, so suturing, teaching those labs, you name it, really, in the sim lab, airway, all of that fun stuff.
Do you try to incorporate all things that we
Yeah.
could take?
Sure. So suturing is a great example. So with that, we like to obviously teach our students anytime you're doing something for a patient, you should be talking them through it, giving them any warnings. So when we're giving local anesthetic, that injection, it's not painless. It does hurt. You need to warn your patients, things like that. You need to chat with them if they want to chat while you're suturing them. Try to make them feel comfortable, make sure they're positioned comfortably. Make sure that once you're finished suturing with them, you're giving them meeting them at their medical literacy and giving them appropriate care instructions to their level that they understand. That I believe also comes in with compassionate care, making sure that your patient feels empowered, they know what to expect, they know when to come back. If they have family members that are overseeing their care, you need to involve them as well, make sure they're on the same page. Yeah, and then on top of that, because I oversee our curriculum, we have and our schedule really, we have some time set aside for wellness check-ins with our students as well. Make sure that if they're starting to struggle, that they are reminded of the various resources that are available to them within our program, within our institution, that they can check in with both mental health, both with their academic resources, their faculty that is available to them. Happy to help them in any way that we reasonably can. And then we have check-ins with our students as well every semester, at least once a semester with our advisees.
Lies.
Yes, yes, that's true.
So,
Sure. Yeah, so oftentimes it's organized chaos. Sometimes it's slightly disorganized chaos, but after, a decade in the ERA, I think I've kind of figured out a little bit about the flow of the ER. I still don't claim to be any sort of expert, but any given day, you come in, you're taking sign out from the incoming team. In our particular emergency department, we're very lucky. We have a lot of support from our physicians. They're great. We have a physician on every case with us who's really supportive. But generally speaking, the PAs sign out to the PAs, and then we'll carry forward with our sign out patients and then start seeing our own patients. Just the other day, I saw probably 7 or 8 patients in my first hour there. You try your very best to go through a patient chart before you see the patient, obviously, unless it's an ambulance that you're walking into blindly. But get as good of an idea of a patient as you can before you go in to see them. You want to know kind of the big picture, broad picture, absolutely reviewing any medications the patient is on. I think that's number one, alongside with vital signs for any patient that I'm going to see, checking out their medical history, their chief complaints, seeing if they had any recent visits, recent hospitalizations. Oftentimes, I'm just looking at the discharge summary for sort of the big synopsis and the big picture, because although we all wish we could, we don't have the time to go through and look through every single note and see what happened day to day for the patient. And so sort of quickly going one room to the next, trying to chart when we can, where we can. I sort of have a mental block personally where I don't like to see the next patient until I've at least done my HPI for a patient. That sort of keeps me on track, makes me feel like I'm not totally scatterbrained. And then making sure you're putting in orders after every patient that you see. The biggest thing I think you need to do after every patient encounter is communicate with the team, the pertinent team members. Be that nursing staff first and foremost, respiratory therapy, the physician if you think it's a critical patient that they need to come see more urgently, just really having communication with one another. And then obviously the patient needs to be informed of what's going to happen to them, how long they're going to be there, and any family members as well. So after that, you're running around. Maybe after every 45 minutes, if you're lucky, you can check back and see what's resulted, try to follow up on any results, follow up with patients when you can, squeeze in suturing, splinting where you can, sneak into a couple more ambulances, and then finally more team members start to come in and your day seems to slow down a little bit. But it's really exciting, really fun. Just you never know what you're going to see. Like anybody, I have some least favorite chief complaints. I really don't love anything that involves the eyeball. I have a mental block about eyeballs, even though I teach our HENT. I just don't love eyeballs. But yeah, that's kind of the day to day. And then after anywhere from 10 to 12 hours, once you're starting to wrap things up, you sign out to your incoming colleague, update patients on anything, let them know that I'm done for the shift and that someone else will be coming in to chat with them with their results, and headed home to chart. That's fine. Yeah. I think I go into every room, regardless of how busy it is, ready to listen to the patient. I think that's my biggest thing. Some people probably could say I should do better with this, but I let the patient talk to me. I let them speak until they're done speaking. I try not to interrupt them unless it has to be a pretty catastrophic reason for me to interrupt them and stop them, because what they're telling me is important to them. They think it's important for me to hear it, and I can't just assume it's not important just because I'm busy, right? So I need to take the time, listen to them, try to focus them where I can, but really let them feel heard, let them feel like they're being heard, And then I always try to remind myself I'm a human, I get frustrated. I wish people would be a little faster at times, right? But I have to remind myself they're in the emergency department because this is one of the worst days for them. They are going to remember this day for years and years and years potentially. And for me, it's another patient. They're another patient, but this could be potentially one of the worst days of their life. So they could be in severe pain, they could be getting awful news. So I really try to let the patients have their moment with me. That first encounter tends to be the longest that I have with them, and then it won't be quite as long from there, but I like to try to create a good rapport with the patient, their family members, and I think that really helps instill trust with the care that they'll receive moving forward. Other ways I try to be compassionate, I always try to ask a family member, particularly older patients, if they're alone, if there's anyone that they want me to update for them, to contact for them. Oftentimes the answer is no, but just letting them know that I'm happy and available to update anybody that they want me to speak with, that I will do, and I'm happy to do it. So I think that's the biggest thing that I do for every patient to instill compassion. And for our team, obviously, I really just try to communicate with our team members and build them up when we all start to feel a little bit, in that like 2 or 3 o'clock hour when the department's exploding. Just try to bring back a little bit of emotional stability for us all. Absolutely. I think that when I first started, I was really eager to prove myself, to see as many patients as I could. I think my mom, she's a pharmacist, and she always talked to me about, the importance of letting people feel heard. And I think she instilled a lot of really good values in me as far as patient care goes. But I still, I wanted my numbers to look good. I wanted the team to feel like, oh, good, Sarah's on today. I can maybe work a little less hard because Sarah's here. But with time and experience and my own experiences, I think I've just sort of realized that it's not about the number of patients you see. I like to give quality care, which is not nearly as fast as some of my coworkers, and I'm not saying that you can't work quickly and give quality care. I'm just saying I would sacrifice on quality if I were to go any faster than I do. So I think I've really focused more on quantity time with patients, having a thorough understanding of my patients, trying to know the ins and outs within reason of what I can about my patients. And I don't know that I was always able to do that when I first started out. And then as far as knowledge, absolutely. I mean, every day still I learn something brand new in the emergency department. I think any clinician in the ER who's reasonable would tell you that they're still learning every day. We all come across new experiences every day, things we've never even had to think about. And it's part of the reason I love emergency medicine. You're always learning. So yeah, I just over the years you compile this whole library of knowledge of things that you can't really even learn in school. It's sort of experiential. So I'm thankful to be able to draw upon all of those experiences.
Great. You've been giving me so many goosebumps along along the way. All right. So
Thanks, Eva.
talking about the quality of the care and the time we spend or the number of patients, right? You kind of said it's still possible to give quality of care and see many number of patients or more number of patients as well. Can you elaborate on that and talk a little bit more about? I mean, many people think if it's compassion, I have to really spend a lot of time. Do you think that's truly accurate? And are there ways where you can show compassion and be compassionate despite not having to spend tremendous amount of time? What are your thoughts on
Absolutely.
that?
Yeah, I don't think that spending a lot of time with patients is the only way to show compassion. It's just a way that I feel most comfortable with my patients. I work alongside so many really skilled, really experienced, really excellent clinicians, nurses, doctors, everybody in our department, our internal medicine team. We all have our different approaches. Some people are really just able to get into the room and get to the meat of the reason the patient is there, and they give excellent care, very compassionate care. Patients remember them. I work with some coworkers who are somewhat notorious for not being in the room very long, but patients remember them. They're like, "Oh, Dr. So and so, yes, I loved him last time I saw him." So length of time does not necessarily equate to compassion. It's the tone you use with a patient, it's the comfort that you make them feel, it's sitting down, taking a breath, not making them feel rushed. And sometimes, as long as you're doing those things, you're calm, you're hearing what they have to say, you're asking those focused questions. That's another way to show compassion. Letting them tell you their whole life story is not necessarily the best thing in the emergency department, nor is it our job really to hear those things. So people, just because they don't approach things the way that I do, it's no better or worse. As long as the patient feels confident in the care that you're giving them, I think that's the biggest thing.
Okay. And do you think that basically the confidence in ourselves, right, in our knowledge and in ourselves makes a difference in the way we provide care and including the compassionate aspect?
I do. I think that confidence is really very important for our patients to feel that confidence coming from us. Especially starting out as newer providers, it's hard to have that confidence. You don't want to come across as overly confident, and it can be hard to fake confidence too. So I do think it's something that kind of grows with you as you become a more experienced clinician. But yeah, I think that it's definitely a part. Yeah. Oh, absolutely. I think as many women in healthcare, I've dealt with imposter syndrome, just like many of us have. So that's sort of a difficult hurdle to come over and to even admit to, but I think that it's gives you some power to admit to that as well. I think that, growing and experiencing more and seeing more and continuing to show up every day helps to build that confidence. And then, there's always these struggles, these things that you trip over. Sometimes when you try to do a transfer to another hospital, that doesn't always go as well, or you feel like, wow, I really could have phrased that better. I didn't sound as confident as I could have. But at the end of the day, we have to pick ourselves up, get that out of our head, brush it off, and then move on. There's always more people to see and our coworkers counting on us. So that you do have to have that tougher skin or learn to get tougher skin in my case, I think. But yeah, there's always definitely some struggles along the way as far as working in medicine. Sure. There's plenty of barriers in the emergency department. Plenty of barriers. Our phones are going off a lot of the time, which can be really disruptive, necessary, but disruptive for ourselves, our thought process, our patients. You're pulled in a lot of different directions. So I can be sitting down and trying to focus on something, but then I get a call that's emergent that I need to go over here and give all of my attention to this. And then sometimes you come back and you forget what you were doing initially, and maybe a half hour, 45 minutes goes by, and the nurse comes over and is like, hey, bed, whatever, has been discharged for a while. Do you have papers? Right, that's what I was doing. And, that's 45 minutes to me that flew by, or an hour sometimes in the blink of an eye. But for a patient, they're sitting there. Maybe they have to go pick their kids up from school. And in the meantime, I've been doing other things and they may be feeling neglected. So there are lots of different barriers. Obviously, even though I like to tell myself I live in a world where my numbers don't matter, how quickly I see people doesn't matter. But as you know, where our metrics are tracked, our productivity numbers are reviewed. So that's always also in the back of my mind. And then just, wanting to be a good teammate for my colleagues, the other PAs. If I'm not seeing more patients, that means someone else has to. So they're getting a little bit busier. So you do have to balance all of the expectations for you within a given day with your preferences. So definitely those barriers are kind of always in the back of my mind. There are. I feel like I compartmentalize them though for like self-preservation. There are a couple of patients that I remember, but they're usually patients that were critically ill, really young patients with bad outcomes. The family members, like their reactions to the happenings. A lot of codes stick in my mind because quite often our physicians are very busy in the room, managing the airway, placing central lines, and while we're off on the side putting in orders and updating family members until the physician is free, which can be hours later. So a lot of those conversations, obviously without sharing any specific details, I can remember rooms of patients, I can remember family members' faces and names, specific conversations, things that I wish I had phrased differently, reactions that I wish I maybe had different reactions, responses to things. Like anybody, I tend to focus more on the things that I could have done better than those positive experiences that I have. But yeah, again, without giving much detail on patients. There, I could probably write a novel on patients that have impacted me. Yeah. I value the friendships I've made in the emergency department with my teammates. It's really kind of remarkable the things that you can see every single day and the people that you can experience these things with, and have bonds that last and go much deeper than most of us probably realize. A lot of trauma bonding, I guess, has occurred between my coworkers and I, even people who no longer work there. We're still regularly in contact. So I think that's a big value, is the respect that I have for my coworkers, and the experiences that we all have. And then, we get up and we witness these awful experiences, and then we go home to our families and we make dinner and we talk about, like, how was your day? And we don't always feel comfortable sharing the things that we've experienced because they can be really difficult, and non-medical people are not always ready to hear those stories. And so we have to respect that too. They didn't choose to go into this career. Other values, I think you really, really respect and learn the value of family when you work in medicine. I know we all have our own experiences with our family members, but when you see some patients, particularly, older patients who may not have many people to rely on, just how you would want to treat your family members, the care you would want to help provide for your family members, how you might want to respect their wishes, their advanced directives, things like that, just to help support your family and make sure you're there to help them, care for them, and give them the respect that they want and they deserve as they get older through life. Other values that I think those are kind of the big ones that I can think of off the top of my head. Yeah, yeah. So my father, who I believe you're referencing, has glioblastoma, so grade 4 brain cancer, which generally has a very poor prognosis. He was diagnosed in my emergency department in bed 4 by one of my colleagues. I had just worked a 6 to 4 shift and went home, and it was 4th of July of 2019. And I got a call from my mom that my father was acting kind of strangely. And it had resolved. And I was like, okay, well, if you're worried, just bring him to the hospital. So I went back to the hospital where I had just been for 10 hours. And, just a few hours later, one of my coworkers came in and told my dad that there was a brain tumor. So that was, unexpected. My dad had been in complete, perfect health up until that point, on no medication. So he was admitted, and then I went home and came back and worked another shift at 6 a.m. the next day. So I think that's one big thing that we need to have compassion for with healthcare workers, is we're all dealing with our own stuff internally, our own family members. Life doesn't just stop when you get into the hospital, right? We all have our own things going on. But yeah, it's been kind of an interesting experience for me, experiencing this from the other side, like you said, the other side of the bed. I will say that his team has been really great in eliciting my suggestions, my opinions, but it is really difficult. There's a lot of red tape that patients have to go through on the other side. I remember even just trying to set up his initial oncology appointments. It was phone calls, phone calls, phone calls, and they wanted to speak with my dad. And meanwhile, he's in the ICU after, a 7-hour brain surgery. He can't speak to anybody. So I'm in there trying to get his signature to get his tissue sample sent to a different hospital and hospitals across the country, and basically just holding his hand up as he's trying to sign, because, what else are you supposed to do? But yeah, it's been interesting. I will say I have noticed that I have a lot more compassion and drive to regularly update patients through their visit in the emergency department. There have been times when my dad has been in the ER, and he, without exaggeration, he has gone 9 hours without any updates. And sometimes he has had brain bleeds on his CT scan that we were not updated about. So it's been eye-opening. But again, so much of this leads back to the fact that everyone in healthcare is so overworked, so overwhelmed, that we don't always have the time to just sit down and focus on the patients in front of us. We're just kind of going next, 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 next. Damage control, damage control. This whole experience has made me sit down and focus and want to keep patients open communication, updated, and make sure everybody understands what's happening, why it's happening, what to expect next. And the other thing that I've learned from this is it's okay to say when you don't know. I don't know the answer to this. We can try and find out the answer. Maybe we'll contact someone who can help with this. So, yeah, those are kind of my overarching experiences. I haven't looked into anything specifically. I would love to hear about some though if you
So, I don't know, probably employing more people.
yeah, have larger hospitals, have more staff, retain the staff that you have, I think is the big one, right?
The retention, right?
Sure. Oh, geez, yes. So, again, anecdotally, just amongst my friends and my colleagues and coworkers, I think that specific to the emergency department, are the hours. That's the biggest problem for us because a lot of us just love the medicine, right? We don't even mind being so busy because it's exciting, but a lot of it is the hours. It's difficult. You go from day to night, to night to night to night to day to mid shift to night again. You kind of just feel like you're constantly in a state of flux, like you've got the flu almost, you're not feeling well. I think that there's a lot of, for again, PAs specifically, there's a lot of pay discrepancy across the various healthcare systems, particularly between specialties. So I think that's a big reason for a lot of turnover. Working for a smaller healthcare group like I do, I'm employed by a smaller private practice. Health insurance for people with families can be difficult. Um, yeah, as far as nursing staff and whatnot, I think it's a lot of the similar aspects for the nursing team is um, why would you want to work in such a high acuity, high volume, high pressure situation as the emergency department when maybe you could work in an outpatient setting with hours that are more amenable to your family for essentially the same pay. So I think those are kind of the biggest issues that I've seen. I think it helps that my husband is not in healthcare, so we don't talk about healthcare at home. He has almost no interest in anything that I do in the emergency department, which I do think genuinely is good. It's a true separation when I get home. I have friends who I speak to regularly, both who are in healthcare and who are, not. And that's, I think, how I do a lot of decompression. I'm talking through things that you want to bounce a second opinion off, or hey, was I right about this? So that helps with a lot of the grounding that you need after a shift. I am very into exercise and wellness, especially with my history as a dietitian. I try to exercise almost every day, except for when I'm in the emergency department. I just feel like that would be torture. So, but just about every other day, I try to do something physically active. It doesn't have to be, running a marathon. It can be going for a walk and listening to my favorite podcast or listening to music or something like that. And then just spending time with friends and family and enjoying that time together, trying to be in the moment and off your phone and have true conversations with one another.
I'm going to see that probably this is going to be joining your favorite podcast.
There
Just
you
kidding.
go.
Just kidding. And how about the coworkers or the team or the interdisciplinary team, the nurses? How do you exhibit that compassion towards them?
I like to say hi to everyone. I mean, I don't know. I guess that's a compassionate thing to do, right? When I come in on shift, I like to try to get to know people. I like to say hi to everybody, or at least make eye contact with everybody as I come in or I cross them and give them a smile. How are you? Just, a short conversation. It doesn't have to be a whole interaction, but just acknowledging everyone. Everyone's job is so important in really any role, particularly I think in the emergency department. It's just good to let each other know you're there for each other, and we're all in it together, experiencing this together. Well, I'm very lucky that my employers are my coworkers because of that private practice that I work for. So, I mean, they probably wouldn't like me saying this, but I barely even think of them as my bosses. They're my coworkers, they're my friends. I feel like I could talk to them about anything, approach them about anything. I think they're very open to suggestion. I personally feel like I'm in a very lucky position where I am. I feel respected. I feel heard. I feel like they give me the autonomy that I ask of them. So I feel like that's why I've been there for 10 years is because of all of those things.
I know I asked you because you are a very compassionate person, right?
Siva.
But do we see a lot of that around us?
Yeah.
What are your thoughts on that?
I think is person dependent. I think it's situation dependent. Sometimes we catch each other at our worst, particularly in those late hours. It can be hard. We see each other in the middle of the night when we're all sleep deprived in some of the worst situations. So I think if you can still show your best side and be compassionate and think of others and put others, if not above you, at least next to you, I think that you're doing a really good job. So I do try to give people grace. I understand that everyone is so overwhelmed, particularly a lot of our specialists, a lot of our consultants, our internal medicine physicians, everybody is just under so much intense stress and scrutiny. So yeah, I mean, it's not always rainbows and butterflies in the hospital, but I do think that there is an underlying layer of respect that is mostly carried through between, just about every interaction. But yeah, you're not wrong to suggest or hint that we could all probably use a few courses in how to conduct ourselves more compassionately. I think, particularly newer graduates and people who are newer to maybe medicine in general, is to keep reading, keep learning, keep studying. Those things can only help you to provide more informed care, which leads to open conversations, two-sided conversations back and forth, which just naturally lends itself to compassion and a give and a take between you and the patient. So just staying up to date on the latest, understanding medicine, kind of those basics. I think being gentle with yourselves and having some grace with yourself is really important. We all can look back and say, "Oh, I wish I did better with that. I wish I had conducted myself more professionally, or I wish I had held it together." But again, we're only human at the end of the day. You need to just learn when to brush things off, move on, pick your head up, and carry forward. And then the very last thing that I think would be a good tip for really anybody is to remember that why you got into this job, why are you there? If I had to guess and look back at when you were interviewing to get into school to be where you are now, you probably said something along the line of, I want to help people. I want to be there to help people. I want to make a difference in someone's life. So just try to remind yourself of those things. And if you're truly at a point where you can't be reminded of those things anymore, maybe it's time to take a little break or step away because that's not good for you and it's not good for patient care, who again, that's who we're there for, is the patient.
Um, we'll do a little rapid fire questions, okay? Now, again, surrounding the same topics, okay?
Okay.
We'll follow up with a few more questions after that. So, if I say compassion, what's the one word that comes to you?
Caring, I guess. Caring. Grace, healing, improvement, book. Oh, I don't know.
In general, any book.
Any book. Oh, geez. I read on my Kindle, Siva, so I can't always remember them.
How about a person or some story that had inspired you um, to stay with you for a very long time?
Oh, I think my dad. Tell my family I love them.
Right?
Sure, he is just such a hard worker. Probably the smartest person I know. He grew up in Los Angeles in a family with three other brothers, and they didn't have much money when they were growing up. And my dad joined the Navy to pay his way through college. And after going through undergrad, spent a decent amount of time in the Navy, then undergrad, and then paid his way for a PhD in neuropharmacology. And he's always just worked so hard to make sure that myself and my family, my siblings, we all had anything that we could ever want. There was no limit to what college we wanted to go to. He was going to make sure that if we wanted to go somewhere, that he would make it happen for us financially. He's just a really kind, giving, caring person. He's very quiet, which has helped me to learn that it's okay to have silence sometimes, especially when giving bad news to patients. You don't always have to say something. Sometimes you can just sit there quietly and let people be with their emotions. And I think I've learned that from him. Uh, he's just a really giving person and just always encouraged me to do anything I wanted and be anything I wanted. And he's incredibly proud of who I am and who I've become and my trajectory. And um, he's a great person.
All
Yeah,
right.
absolutely. Yeah. Oh, I wish. I guess just kind of overarching, I think like most of us that we wish that these metrics didn't have such a weight on us and have so much impact on our performance and our pay at times and reimbursement and really just judgment on us as clinicians when they seem somewhat arbitrary at times. I guess I see the point in some of it being meant to encourage us to be more productive. Look at me, for example. Would I sit in a room with a patient for an hour if you let me? Sure. But I can't because somebody is watching that and making sure that that's not what happens. So it's a double-edged sword. I can't claim to know everything about the metrics and bounce back criteria, for CHF patients and all of this. And really just, I wish that I understood the data behind it, what they're using to base a lot of these numbers, like the sepsis bundles and whatnot, what metrics they're using, and data and research based studies they're using to support these specific numbers and metrics that they're recommending. So I guess more education on my part is needed. I don't think I have. I think that mentally I feel the frustration with them and I commiserate with everyone about them. But we have so many little like pop-ups on our EMR that I feel like with a lot of these metrics I can just click them and then push the things requested of me and then they go away. But honestly, it feels like every time we have a billing and coding session or lecture or seminar, we're told about two new things that we have to include for this or that, or for tracking numbers or what have you. And it sometimes just feels like, at what point are we supposed to be seeing patients? If we're supposed to be doing clicking all of these boxes and making sure we do this at this time, when am I with the patients? But on the opposite side, then the patients get Press Ganey scores and they say we're never with them. So again, it's so tough to juggle. Sure. I mean, it's patient specific, scenario specific. I sort of look at it as the boy who cried wolf, right? So just because they're back again for X, Y, or Z complaint doesn't mean that this time there may not be something real. Um, Maybe someone who has chronic abdominal pain without underlying pathology, maybe this time they have appendicitis, right? So you still believe the patient, you believe their pain, you give them the same workup that you would give anybody else who presented because today is different than yesterday, is different than tomorrow. And you never want that patient to suffer some kind of horrific outcome just because you brushed them off for whatever reason. I think that again, believing the patient, treating their pain until you're given a reason to quote unquote not treat their pain is the biggest thing. It can be really tough. I mean, we talk a lot about implicit bias in education, reminding ourselves, if you're feeling particularly charged about a certain patient or a chief complaint or someone with substance use disorder, then take a step back, ask why are you feeling this way, and then again, remember the patient in front of you with your clinical reasoning, your clinical judgment. And then having those conversations with the patient, if you feel ultimately after your workup is done that they may be there for secondary gain or trying to have a refill on our narcotic script, just having honest conversations with them, letting them know hospital policy is your concerns for them, and then offering them any additional resources that you can, getting case management, social work involved if need be, and if the patient will allow it. I think you did a really good job overall. I'm trying to think of anything, Siva. I don't know. How do you feel from your standpoint, the emergency department? How do you feel like we interact with the medical team? I know it's a little bit different now than that we have the chat where we admit patients to you, but is there anything that you wish that we could do differently to support you better in your role?
So,
No, I mean, I think regardless of who's watching this, I think that understanding that being a patient or being a healthcare provider, it's difficult for everyone. We're all experiencing our own lives, and sometimes we meet up in the hospital, and we have to understand that somebody in front of you is not just a patient, just like the person in front of you is not just a healthcare provider. We're all living our lives where extraneous things are happening to us and impacting us. And like you said, we're all just doing our best. I think it
right.
starts with yourself. Self care is key. If you can't care for yourself, you cannot care for others. I'm a strong believer in that. I'm not saying to put yourself above others. I'm just saying treat yourself at least with the respect that you would treat other people around you, and give yourself some love and grace. Yes, it was fun to talk about these topics.